Hello all, I'm Dr. Shweta Sonthalia, the course director and founder of MRCOG, and I'm glad to see you all today to discuss about peripartum hyponatremia, which has been published in 2022 volume 3 TOG. And you all know that in this July exam, there were questions from this talk. So definitely it's very, very important from exam point of view. And this is something, a new concept has been introduced, saying that it was underreported till now. So this really needs our attention and how to tackle this, because this can affect the neonatal as well as the mother outcome in a significant way. So we should know about this. This is not a very big talk, but this is really, really important from exam point of view as well as the new concept. So yes, you can surely get this question from this talk in your Jan exam. So let's start. So if we talk about hyponatremia in labor, it's common but underreported. Why it is underreported? Because we don't check it, right? We don't keep checking electrolytes for a laboring women. So it's underreported. But it's important. It can cause considerable complication, altering the management of labor, fetal and maternal outcomes. So we should check for it when needed. And this is what we are going to highlight in this session today. So pregnant women are predisposed to hyponatremia because of the physiological change in water and sodium hemostasis. So we all know that pregnancy is a state of water retention. Approximately 6 to 8 liters of water is retained during pregnancy. Why it happens? Why the body doesn't get rid of that extra water? Because the body osmolality has been set to a lower level and body is happy with that. So it's a new homeostasis achieved with a lower sodium level, body is happy, and there is water retention and body is happy. So this is what physiological change of pregnancy, which automatically leads to lowering down of sodium physiologically from 135 to 130. So automatically there is a physiological drop, and if it drops further due to other reasons, then it becomes detrimental for the women as well as the baby. So most important thing is prevention. Prevention is the key, but at the same time, early recognition is also what we can do to avoid the detrimental outcomes. How we can recognize it, how we can prevent it, by doing fluid balance chart alongside the partogram. We all do partogram for our laboring women. If we also do fluid balance chart in that, it will tell us if there is positive fluid balance of more than 1.5 liter happening, which is a risk factor for low sodium and which can lead to bad outcomes. So fluid balance chart is something which will tell us that the woman is going towards hyponatremic state, which can be detected by electrolytes level, and then extra precaution can be taken. Women can be treated for the same. Most of the time it is mild and well tolerated. Mild means from 130, as the new set in the pregnancy is 130, the lowest level. So if it goes up till 125, somewhere between 130 to 125 is something which only require your attention, not much of treatment, not a treatment by sodium or something. So it's the level when it drops below 125, that is the main thing which leads to risk to the mother and newborn. So if we talk about renal physiology and sodium hemostasis in pregnancy, during pregnancy, the renal system get many adaptation. We all know that creatinine level fall in pregnancy because the creatinine clearance increase, urea level fall because of hemodilution. Also, there is sometimes hydronephrosis, which is physiological. So these all things, the changes in pregnancy leads to, there could be proteinuria, glycosuria. So these all things we know that during pregnancy this happens. Structural changes like hydronephrosis also, and functional adaptation related to the pregnancy. But pregnancy is a state of positive water balance. There is accumulation of 6.5 to 8 liters of fluid by third trimester, which is a quite significant retention, isn't it? So plasma osmolarity decreased by 10 milliosmol per kg and falls to 280. So osmolarity decreases to 280. It happens from 10 weeks of gestation itself until 1 to 2 weeks postpartum. So approximately 900 to 1000 millimole of sodium is retained to maintain the extracellular volume, but still the pregnancy is hypervolumic hyponatremic state because of the change in the homeostasis. Change new set of body to the lower osmolality. Body is happy with the lower osmolality and keeping it low. So it's a hypovolemic hyponatremic state where the level of sodium decreases from 135 lower level to 130 in pregnancy. This is something we have to remember well, because they can ask you anything that what's the normal sodium serum level in pregnancy, or how does the osmolality, what happened to the osmolality. Sometimes there are long options like osmolality decrease or increase, sodium retention happen or not happen, sodium level decrease or increase, water balance is positive or negative. So these all things you should keep in mind, then only we will be able to understand that how sodium level get lower further and can lead to symptoms. So what are the risk factors? Why this happen basically? Why peripartum hyponatremia happen? Why there is electrolyte imbalance? So in peripartum period, there is greater risk of hyponatremia and can present as water intoxication in labor. Commonly it is known as water intoxication in labor. So from where this water intoxication happening? Why the water is becoming so much that is dropping the level of sodium? Why this water retention in the body at the time of labor in the peripartum period? So if you see, because we already saw there is lower baseline sodium in pregnancy, and the other things are labor-related nausea, vomiting, stress, pain, starvation, leads to increased antidiuretic hormone secretion. So this is the main thing, increase ADH level, which leads to what? This is antidiuretic. So it will retain the water. If water will be retained, sodium will fall. So antidiuretic hormone is mainly responsible for this. Why this increase? Because of labor-related stress. So there is automatically an antidiuresis and physiological oliguria in labor. So if prolonged labor happens, then the effect will be further aggravated. If we give oxytocin augmentation protocol for a longer time, sometimes oxytocin is started for induction and then augmentation. So oxytocin is also a similar structure like ADH, only differ by 2 amino acids. So oxytocin also can act like ADH. Oxytocin is also antidiuretic. So if somebody is receiving oxytocin for a longer time for induction augmentation protocols, then they are at risk of hyponatremia, which we all should understand, because we all are using oxytocin in our labor ward, day in, day out. So we should be keeping our mind alert regarding the relation of oxytocin infusion and hyponatremia, the relation of prolonged labor with hyponatremia, the relation of stress of labor with hyponatremia, so that we can monitor it. Excess of IV fluid. If we give them some of the hospital or some of the unit follow this protocol of 125 ml per hour of IV fluid for the laboring women and keeping them not to nil by mouth. So different unit have different protocol, but if you give them too much of IV fluid, and if there is a positive fluid balance of more than 1500 ml, they are at risk of hyponatremia. So we have to maintain a strict input output chart to understand what is the fluid balance for that laboring patient. So we understand if she's at risk of hyponatremia. Then the neuraxial analgesia. We all know about epidural analgesia. We regularly give epidural analgesia in labor. So epidural analgesia also lead to physiological hypovolemia. That's why you must have noticed sometimes after giving epidural, suddenly the CTG become bad. Suddenly there is bradycardia episodes. That is because of hypotension. So then we give fluids. If CTG is abnormal, usual protocol is left lateral position and hydration. So if we give too much fluid at that time, that makes a positive fluid balance. So we should be careful about the intake output chart at that time. If we give dextrose infusion, if we give insulin infusion, the sliding scale for diabetic women laboring, then we always keep dextrose ready for them. If we have to give dextrose to any women, she is further, because dextrose doesn't have sodium, so it will further lead to dilution and hyponatremia. So dextrose infusion is also a risk for hyponatremia. So these are the reasons: simple physiological thing, prolonged labor, oxytocin augmentation, positive fluid balance, analgesia like epidural analgesia, dextrose infusion with sliding scale, which all lead to peripartum hyponatremia. Am I making sense? Am I clear? Okay, great. Then again the clarity about ADH secretion and oxytocin effect. During normal labor, we all saw that the secretion of ADH increased. So greater amount of water will be retained, right? Because it is antidiuretic hormone. And there is physiological oliguria in labor. Because of oliguria, there will be fluid retention as well. Oxytocin is also having antidiuretic effect. So this will also retain fluid. So all of these are going to retain the fluid, leading to hyponatremia. Oral IV fluid and food intake, we all know some of the units follow different protocol for the laboring women, how much to give food. If they're high risk women, we have to keep them NBM. So different protocol, different places. But if there is prolonged intensive parturition, dehydration, decreased oral intake, all this will lead to hyponatremia, as well as the iatrogenic fluid overload, which we should keep in mind. So this dilutional hyponatremia is related to IV fluid administration, which is less than 1% if it is less than 1 liter, which will increase to 26% if they receive more than 2.5 liter. So how much fluid you give to the women, how much IV fluid you give, how much oral and IV combination, whatever they're taking, how much total fluid they're taking. If it is more than 2.5 liter of IV fluid administration, then it will lead to dilutional hyponatremia, which we should keep in mind. So all laboring women who has positive fluid balance of more than 1500 ml, we should think about hyponatremia. We discussed about epidural, we discussed about insulin infusion regime. All these are responsible for fluid overload and hyponatremia. So what we should do? We should monitor the sodium, right? And we should follow the sodium pathway. So if these are the risk factor available during labor for that particular patient, if she's on oxytocin infusion or positive fluid balance or dextrose with insulin, or sodium is 130 or less. As I told you, 130 is the new lowest set for the pregnancy because of new homeostasis. So if it is lesser than that, then we have to put the women to sodium pathway to keep checking at a particular interval, which we'll discuss about in the management for that particular patient, because she's already having less than 130. So that is hyponatremia in pregnancy. How the women will present, what will be the clinical picture? Most of the women tolerate hyponatremia without any clinical signs. So most of the time, like in labor, the woman is already anorexic, she's tired, she's lethargic, her muscle tone is weak because she has not eaten, she's under so much stress. So the clinical picture of hyponatremia is also similar like that, tiredness and lethargic and not feeling like eating and all that thing. So we can't practically differentiate the labor symptom from hyponatremia symptom. But yes, when the level falls significantly, like if it goes below 120, then it is going to lead to severe and rapid progressive neurological sequelae. So we don't want to go to that stage. We want to pick it up somewhere between 125 to 130 itself when it is mildly low, because less than 125 could be very detrimental. So this clinical presentation is non-specific, so difficult to diagnose. And if you diagnose, it's quickly reversible with prompt management, and you can avoid the neurological disability and death. There are few case reports of concomitant cardiac arrhythmia as well. So it is harmful for the patient. Even the patient can have fits, can have neurological problem, can have death can have a cardiac arrhythmia, which could be very, very detrimental for the women, right? So early sign would be headache, anorexia, nausea, lethargy, apathy, as I told you, just like labor symptom. But moderate or severe will lead to disorientation, agitation, seizures, depressed reflexes, coma, respiratory arrest, and pulmonary edema. So this is something we want to detect. First of all, prevent, then do the early recognition, and then do the early treatment so that we don't have this complication for the laboring women. So first of all, we have to have the insight that it can happen, how to avoid it, and if it happens, how to treat it. So what are the differential diagnoses? There could be many differential diagnoses of hyponatremia, basically. And there are three types: hypovolemic, hypovolemic, and euvolemic, depending on the volume of the body fluid. So the causes could be related to hyperglycemia, related to diuretics, mineralocorticoid insufficiency, GI losses, pancreatitis, trauma, peritonitis, hypothyroidism, adrenal insufficiency, low intake, cardiac failure, liver failure, nephrotic syndrome, preeclampsia, very, very important. Preeclampsia can lead to hyponatremia, and sometimes the seizures are because of hyponatremia rather than eclampsia. But ultimately, you have to treat with magnesium sulfate. That's all right. But in preeclampsia, electrolyte checking is very, very important, because preeclampsia also lead to hyponatremia because of the changes in the body. And then the water intoxication. So sometimes they might ask you, which of the following conditions are associated with hyponatremia? Which of the following conditions are the differential diagnosis of hyponatremia? So you should just have an idea about what are the situations where you can get hyponatremia. Before going to management, just wanted to emphasize about our mega course, which is 7-month course, which includes free crash course. Now it is on 50% off for next 3 days. So if anybody is interested, they can join. These are the course feature. We cover more than 125 talks in the session live, which really makes a difference in exam. So all the important exam topics which are coming in the exam from the talks, as well as all the GTG, NICE, all the guidelines are covered in the course. It's an extensive course of 7 months, which includes regular course plus free crash course. So if anybody is interested in thorough preparation from the beginning, a right way of right start, then you can join us. Okay, so if we talk about management of hyponatremia aims to prevent the onset of symptom and the adverse effect so that we can improve maternal and neonatal outcome. So if serum sodium level is less than 130, then we should start the treatment, right? If less than 125, then we should stop the oxytocin infusion, which is very, very important. They can simply ask you in SBA that they give a level to you and they ask you that what you are going to do, how you are going to manage. So you should know that less than 125, you are going to stop oxytocin and get the senior input. If severe symptomatic, then you require an MDT approach, because she will have neurological symptoms, seizures, coma, respiratory arrest, cardiac arrhythmia, pulmonary edema, which is not solely your forte to treat. So you need anesthesia, medical team, sometimes critical care team to deal with. So you need to have a multidisciplinary team. Critical care medical specialist outreach team might require some time if all this severe symptoms happen. If the level goes below less than 125 and after modification of the fluid intake and oxytocin infusion stopping, you can't control it, then you might have to give sometime hypertonic saline, which is 2.7% of NaCl. So if severe symptoms, you have to give hypertonic saline sometime to correct the sodium. So if you go in this chart, which is very, very important, and most of the question will be from this chart, obviously, about management. So when you're going to monitor, first of all, if there is oxygen infusion, if dextrose, if positive fluid balance, or if the sodium is less than equal to 130, you're going to monitor. Now, what you're going to do? If it is more than equal to 130, you will not do any fluid restriction. No need of doing anything other than repeating the sodium if the risk factors still persist in 8 hours and if the positive fluid balance is there. So only one thing you have to do, which is repeat sodium in 8 hours, if the situation remains like that. If she delivers and things changes, no need. But if she's in labor, all these are going on, and then if you see that the sodium level is somewhere between 130 to 135, then you have to repeat it in 8 hours if the situation persists. Now, if the level is 125 to 130, which is where we want to prevent it from going to less than 125, what we have to do? Definitely we have to do something. So we will restrict the fluid to 80 ml per hour, which is also the fluid restriction for severe PET, right? So you can remember it like that, 80 ml per hour fluid restriction, and repeat sodium in 4 hours. So you have to do two things. Here you have to do only one thing, which is repeat sodium if needed. Here you have to do two things. One is restrict the fluid to 80 ml, and second is repeat sodium in 4 hours. So any patient in your labor ward round, recently we had a patient whose sodium level was 126, which was definitely low. And then before we restricted the fluid and the plan was to repeat it in 4 hours. But before we could repeat it, she delivered the baby. And then, unfortunately, the baby had seizures. So this is how this low sodium can have a detrimental effect on the baby. So it's very important to inform the neonatologist that she was having a low sodium, because low sodium can lead to like a hypoxic effect for the baby, like hypoxic ischemic encephalopathy due to hypoxia. The same way low sodium level increases cerebral edema and the symptoms of hypoxia can be mimicked. Baby can have seizures. So it's very, very important for us to optimize the mother sodium level so that the baby doesn't suffer because of that. So restriction of the fluid to 80 ml per hour, very, very important. And repeat sodium in 4 hours is what you have to do and inform the seniors and neonates. If the level is less than equal to 125, what to do? What to do? This is something very, very serious. So you will restrict the fluid to 30 ml per hour, which is severe fluid restriction. And at the same time, you will repeat the sodium in 2 hours now. So 8 hours, 4 hours, 2 hours repeat. You're very worried, so you decrease the fluid significantly and repeat sodium in 2 hours, and you will stop the oxytocin. Here, the role of oxytocin, you have to stop the oxytocin. So here, only one thing, repeat. Here, restrict the fluid and repeat sooner. Here, restrict the fluid further, repeat further sooner, and stop oxytocin. So 1 action, 2 action, and 3 action. Remember like that, so you'll never forget. You'll never miss anything. And then again, here you have to have the MDT input. Here only senior obstetrician is enough. Here require MDT input. Very, very important. And then if the symptoms persist, like the agitation and mental symptom, neurological symptom persist, then you have to involve the CCU. Then you have to correct it because the fluid restriction didn't improve it, symptom persist. So you have to give her hypertonic saline, which is 2.7% saline, 200 ml in 30 minutes. So in exam, they can ask you what saline you are going to give. So you should remember 2.7% saline in place of 0.9%. The usual NaCl is 0.9%. So in place of that, you are giving 2.7% saline, which is hypertonic saline, 200 ml in 30 minutes, which is a quick correction. Why you are doing quick correction? Because the sodium is leading to hyponatremia, is leading to severe symptom for the patient. Otherwise, sodium is not preferred to be quickly corrected, because that quick correction can also lead to neurological problems. But here, because of the severe uh, low value and persistent symptom, you have to correct it by hypotonic saline. And if there is any fluid overload, you can give furosemide IV 20 milligram, which will help with further decreasing the volume and increasing the sodium. So this is what you have to do. This is very, very important. This chart is really, really important for your exam. So this time they ask from this category. Next time they will ask from this category or this category. So you should remember it really, really well. Then about after delivery. So if the patient is in labor, this chart you are going to follow. If the patient is not in labor after delivery, you have to check her sodium. Supposedly, one patient was having low sodium, so the plan was to repeat. Like this, I told you, our patient was having 126. So we should have repeated it in 4 hours. Before that, she delivered. So now we have to repeat it in 4 hours. So we will repeat it and she'll be after delivery. So again, we have to check in which level her sodium is falling. So after delivery, as I told you, during labor, the patient already go to oliguria, and after delivery, the polyuria phase will start because the stress is over. The ADH level will decrease. So if after delivery, her level is more than equal to 130, you are happy. Nothing to be done. While in labor, you repeated it. So it will be one step lower after delivery as already the body is sorting out the problem. Already the ADH is decreasing in the body. So more than 130, don't do anything. More than equal to 130, don't do anything. 125 to 130, now here you will go in this stage. So it will be, as I told you, it will be one step de-escalation. So here what you have to do, no fluid restriction, like the first category there, no fluid restriction unless clinically indicated, and repeat sodium in 8 hours. This is what we did for more than 130 in labor. And here we are doing for 125 to 130 for post-delivery. No fluid restriction and repeat in 8 hours. And discuss with the ops and anesthesia team. So this is what you will do. Post delivery, if it goes less than 125, the fluid restriction will be same, 30 ml, and repeat will be in 4 hours. So there it was 8, 4, and 2. Here it is no action, repeat in 8 hours and repeat in 4 hours. And again, stop oxytocin and fluid restrict. Because less than 125, the treatment protocol will be same. Restrict the fluid to 30, stop oxytocin, because that's the reason. Because less than 125 is something can lead to severe symptom. We can't ignore it. We have to treat it. But postnatal, this level is not much of concern. So you will just repeat the level in 8 hours is what you will do. No treatment required. But even in postnatal, if it is less than 125 or less than equal to, you are very serious about it. So 30 ml fluid restriction, stop oxytocin, but repeat will be in 4 hours in place of 2 hours in labor. So that's the difference. Again, here it will, the MDT requirement will be there because 125 very less and treatment will be required. But here you won't be needing the hypertonic saline and furosemide, all that might not be needed because as I told you, body already started the correction. So fluid restriction, stop oxytocin, and repeat in 4 hours is what you're going to do after delivery. So there is a difference in intrapartum and post-delivery. So be careful about that. In the question scenario, what they're asking. Now, if we talk about neonatal outcome, it can cause severe neonatal outcome, adverse neonatal outcome, as I told you, because whenever the mother has high ADH secretion, it also leads to fetal high ADH secretion. So because of the hypoxic stress, because of the cranial pressure, the baby also have higher ADH secretion. Baby also have antidiuretic effects of fluid retention. So baby already is prone for hyponatremia as well. So if the serum sodium level go below 125, it can lead to deterioration of the cerebral edema and risk of neonatal seizures like with HIE. Maybe baby require therapeutic cooling. So it's very, very important that we optimize the sodium level for the mother so that the baby's level can also be optimized, because whatever level of ADH is in the mother, whatever fluid mother have, the fluid retention because of antidiuresis, the same homeostasis is achieved by the baby as well. So baby also will have high ADH, baby also will have hyponatremia, and the baby will be having the risk for seizures. So this is all about peripartum hyponatremia, the detection part, how you are going to follow, how you are going to manage it is very, very important, which you should remember. And what are the risk factor, what are the differential diagnosis. As this TOG is, I'm sure this TOG will have question, will give you question in Jan 2024 exam of part 2. So all the best for your preparation, and if anybody need any help or if you want to put any comment, please put in the comment section and subscribe to the YouTube channel so that you get update about the latest videos. All the best for your preparation. Bye.